I'm Dr. Alexis Cogswell, and I'm here today with Dr. Premal Thaker. We're going to talk about platinum-resistant ovarian cancer. There have been a lot of developments in the past day and a half. We've got Keynote B96. We've got multiple targeted regimens.
Yes.
How are oncologists going to make sense of all of this back up?
Yeah, so I think it's exciting, right? Because platinum-resistant ovarian cancer is the hardest for us to treat, and every ovarian cancer patient who unfortunately recurs ultimately becomes platinum-resistant. So all these drugs are necessary, as we can tell that we need to extend life and quality. But I think the biggest splash, of course, was Keynote B96. It's part of the presidential, lectureship of featured abstracts. And we really got to see finally the data by Dr. Colombo showing us that it really demonstrated the benefit of pembrolizumab with weekly Taxol and bevacizumab versus weekly paclitaxel and bevacizumab. And what was really interesting for all of us who studied this for so long is that this was the first immunotherapy combination that worked. We had so many negative trials in upfront, platinum sensitive, platinum recurrent, and this was the first one. So, I think a lot of us are still trying to unpack all the data, but, for key strengths are that it is really what we use as our standard of care. Paclitaxel with bevacizumab for the control arm had both, because, some of the other trials like Corland only had nab-paclitaxel without the bevacizumab component, was exposed. But I think some of the things why this may have worked a little differently is that we are giving metronomic paclitaxel, which we know is more anti-angiogenic and also maybe more helping symptom with immunotherapy. A lot of the other taxanes we're given have been on 3 week, and so maybe that in addition with the bevacizumab plus some synergy. So it was nice to see because it had the PFS benefit as well as the overall survival benefit of about 4 months, which is where we sort of see rituximab, Rosella all having similar. So it tells us it's very much in alignment. This is our first phase 3 that's so large that gave IO a chance, which is great.
Exactly, but what biomarkers are you using to select that population? Does it matter if they're high CPS, or are you going to make? Is this something that you consider for all?
I am not a big believer in the CPS score in gynecologic oncology. I
It's
feel
a
like
weird one.
It's a very odd one. If you look at everyone else's diseases, they have like higher cutoffs, and ours is so low. It's less than 1 or greater than 10. Excuse me, greater than 1 or greater than 10. So if you think about when someone's looking at an IHC slide, trying to get a score greater than 1 is a pretty low bar.
Yeah.
Because there is heterogeneity, but it's just not as high as like greater than 50 or greater than 20 or something like that. So
Like our lung cancer
like
trials,
lung cancer.
so have to use high cutoffs.
I know, so that's why when we use ours, I feel like almost embarrassed to use a CPS score because I'm just like, come as far back.
Just fall over the bar, right?
Yeah.
That's interesting.
But I do think, what's nice is to have an option for patients who don't have a biomarker because, right now for mirvetuximab, you want to go with receptor alpha high, greater than 75%, or if you want to use a combination with that, you can have a little cutoff, but if you're less than 20%, you don't have a chance to use like mirvetuximab.
Sure.
So I do think it's nice because we have lots of patients who exact to this point who don't have a biomarker for HER2 if they're not HER2. So, and there's obviously clinical trials which we're all passionate about to make these happen.
Absolutely.
For successes for patients. But I think it gives us another option as well. And I think it'll be easier, as I mentioned yesterday as a teaser, that the FDA will be evaluating this. So I think it's very easy to incorporate and adopt because pembrolizumab is used so commonly in a lot of other diseases like endometrial cancer, cervical. So for people, it's not going to be like a new MOA to understand. They already are very well versed. So I think adoption will really help because patients also want immunotherapy. Every ovarian cancer patient, every ovarian cancer patient's like, I see the ads, like, why not me? I'm like, well, it just hasn't been happening until
Says now, which is great. Absolutely great news. Now with so many different treatments coming down the pike, and I know you've worked on some really innovative trials that are investigating immune biomarkers and different targets that we've not seen before. How are those going to be sequenced? Do you anticipate people gravitating towards the IO first and then following up with targeted or vice versa?
I think, to be honest, for a lot of what we had also step back is a lot of our ovarian cancer patients are treated by medical oncologists in the community, and since they're so used to giving pembro for so many diseases, like I think we will all come now with prior pembro, because there was a phase 2 by Dr. Tumors that looked at metronomic cyclophosphamide, pembrolizumab, and bevacizumab, and a lot of us adopted that because that is on the NCCN guidelines, and there was not a phase 3 that had similar data. So I do feel like people have been trying to, incorporate the use of pembro even before B96 because we all wanted to live with it. So I do think some of the ABCs may get pushed back a line, because they may not be familiar with the testing since folate receptor alpha is not a big target in a lot of other disease sites.
Right.
So I do think it's going to sort of now change the sequence of what platinum-resistant ovarian cancer will look like, and also how will that impact when you want to use another taxane agent after you use this, because these mirvetuximab's backbone is an MMAE, which is very similar to a paclitaxel or taxane, a mitotic inhibitor, and that can cause more neuropathy and everything. So now it's going to be side effect balancing of how you not only payloads but side effects to try to really figure out how to sequence our patients the best, so they also have good quality, because we haven't get cured it, so we need to make sure they're living on quality as well.
Right. It's all about quality of life, not necessarily quantity of years.
Yeah.
I think especially for patients with platinum-resistant ovarian cancer, some of them get into the cycle where they think platinum is always going to work. They've had platinum so many times and it just always works. How do you approach those conversations with patients, and when do you start talking about platinum resistance?
Yeah, so as soon as patients sort of recur, I sort of start introducing at least that this is now not curative. Not to take away hope, as I tell every patient, but just to help them understand the balancing act is different. Right? Because if I told somebody that we can cure you, they would take 6 drugs, whatever cocktail, and do it all. But unfortunately, we're not at that level once you recur. So it's more of saying, having that discussion of, yes, if you're platinum sensitive, that's great. But I also start talking about the platinum-free interval becomes really important to understand what the expectation of those responses. Because a patient who's 2 years and it recurs after receiving platinum, it's very different than someone who's 8 months after just finishing chemo. And I think that is sort of the art of discussion with patients, because patients make very interesting decisions, about also how frequently they want to come to the doctor's office, right? So I've had patients definitely in the first recurrence be like, I want a weekly regimen.
Right.
I understand it might be helpful, but I want to not, once a month, I want once every 2 weeks, have a couple of weeks off. And those also play a big role because, it's really part of that joint decision making.
Absolutely, and that's a really great note to end on, is that I think we're still in a stage where everything is joint decision making, and it's great news that we have all these new options for these patients.
I know, it's very exciting because, a lot of the targets that we already know about that we've not seen as, some agents have failed are now resurrected, and so it's just good to see that cancer biology is still ongoing.
Oh, I know.
And that's what I really love, right? Like that maybe we tweak the molecule so it's more tolerable or has a better efficacy.
Better safety profile, like we were seeing with Navistar. And they really engineered that antibody, and that's very interesting data coming out.
It was, because it's like we all sort of gave up on that B2B, for years we were talking about it.
I was so excited about UpRe. It was really heartbreaking.
Yeah. So hopefully we'll have better options for patients in the future.
Well, that's great. We really appreciate you talking with us, Dr. Thaker, and look forward to speaking with you again very soon.
Yeah, thank you.